My name is Dr. Melinda Mushonga, a radiation oncologist from Kingston General Hospital and Zimbabwean-trained clinical oncologist. It is an honor to be presenting a significant topic which allows optimization of radiation therapy in the African context, choosing wisely radiation oncology, and at the same time offer my most sincere apologies that I could not do this in person. I have no pertinent conflicts of interest to declare. The oncology community is now well aware of the growing burden of cancer and increased mortality, particularly in Africa, where both incidence and mortality are at par according to the 2020 Global Can data. The cumulative risk of death from cancer is higher in Africa than other regions, and unfortunately limited resources in low-middle income countries hinders optimal management. Optimization of current infrastructure, in particular transitioning countries, is therefore critical for an equitable global cancer control. This includes resource-intensive interventions, which include appropriate utilization and optimizing radiotherapy within established radiation therapy centers. Radiotherapy is a fundamental component in cancer care, and Africa houses less than 4% of the world's radiotherapy missions. This is on a backbone of most patients presenting with advanced stage disease, and radiotherapy is a critical component for both curative intent and palliative indications during treatment decision. But what is the current state of radiation oncology in Africa? As I elaborated earlier, there's a lack of resources and infrastructure, including lack of radiation oncology specific treatment guidelines, guided by locally generated clinical evidence. There's limited access to treatment as there is a lack of sufficient radiation therapy centers and shortage of skilled healthcare professionals in the public sector. How then do we ensure access to radiation therapy? Several factors come into play. However, choosing wisely our treatment plans becomes critical to achieve this goal. The Choosing Wisely initiative was established in 2012 to support the delivery of safe, cost-effective care. This remains particularly relevant in low-middle income countries as it promotes discussion between clinicians and patients about care that is supported by evidence, does not duplicate other tests or procedures already received, free from harm, and truly necessary. The Choosing Wisely Africa was built upon Choosing Wisely Canada, USA, and India, established in 2020 at the AORTIC regional meeting. This was through a modified Delphi process with representatives from surgical, medical, and radiation oncology in the private and public sectors, including patient advocacy groups who participated. Ultimately, 10 low-value common interventions in Africa's cancer practice which should be avoided were identified, 6 of which are relevant to radiation oncology as well. How do we implement Choosing Wisely in radiation oncology? Several factors can be considered, and these include utilizing more hypofractionation in our treatment decisions, especially in the curative setting, omission of radiotherapy if clinically indicated, use of radiotherapy in the neoadjuvant setting if clinically indicated, as these in most cases allow for shorter courses of treatments compared to the adjuvant setting. De-escalation by excluding very low-risk volumes, for example in head and neck cancers, and use of shorter fractionation, split course, and quad shot in the palliative setting. Breaking down the 10 low-value common interventions to be avoided from Choosing Wisely to focus on the 6 applicable to radiation oncology. The first one is, do not initiate cancer treatment without defining the extent of cancer and discussing the intent of treatment with the patient. An established intention to treat, curative versus palliative, and the role of neoadjuvant treatment considerations, and for those with metastatic disease, considerations of shorter palliative regimens becomes possible. Do not decide treatment of potentially curable cancers without inputs from a multidisciplinary oncology team. Consolidating from the first point, it allows decision on role of neoadjuvant therapy, which may include radiotherapy. This may also potentially reduce the need for adjuvant therapies, for example, in the setting of positive margins, which are likely avoidable with optimum neoadjuvant therapy. Do not perform surgery to remove a breast lump without histologic confirmation of malignancy unless a needle biopsy cannot be performed. Inadequate surgery compromises oncology outcomes as there is a high risk of positive margins requiring more intensive adjuvant treatments. Do not treat low-risk clinically localized prostate cancer, e.g. Gleason score less than 7, PSA less than 10, tumor stage less than T2, without discussing active surveillance as part of the shared decision process. This avoids unnecessary radiation-induced toxicity when radiotherapy could be avoided. Do not initiate longer courses of radiation therapy where evidence supports the use of shorter courses of radiation. For example, use a single fraction of palliative radiation for an uncomplicated painful bone metastasis and use shorter courses as a part of breast conserving therapy in women with early stage invasive breast cancer. Both clinical scenarios outlined have level 1 evidence supporting hypofractionation as a consideration. Do not use surgery as the initial treatment without considering pre-surgical systemic therapy and/or radiation for certain cancer types and stages where it is effective at improving local cancer control, quality of life, or survival. There is strong evidence on the role of neoadjuvant treatment, for example, in colorectal cancer, esophageal cancer, and lung cancer for superior sulcus tumors. Choosing wisely in radiation therapy increases the chances of much improved care plans and clinical outcomes, as there is likely better compliance when patients have shorter treatments, in addition, financial relief and reduced pressure on resources. Clinical outcomes are better as radiobiologic models suggest a larger daily dose is effective for malignancies with a low alpha beta ratio, for example, breast and prostate cancers. Focusing more on hypofractionation as a strategy. What is the evidence available for hypofractionation in practice for common clinical scenarios? Several trials have shown non-inferiority between moderate hypofractionation and conventional fractionation. Therefore, this has become standard of care in most international guidelines for early-stage breast cancer. For node-positive breast cancer, most high-volume institutions have also adopted moderate hypofractionation in this high-risk group, guided by a few randomized controlled trials and single institutional retrospective data supporting its consideration. There are, however, other clinical scenarios, such as inflammatory breast cancer with limited clinical evidence, where conventional fractionation remains relevant, therefore considered standard of care. Ultra-hypofractionation has been adopted in particular during the COVID pandemic. The 5-fraction schedule in early-stage breast cancer was shown to be non-inferior to moderate hypofractionation with favorable toxicity profile after 5 years follow-up. However, a slightly increased risk of inferior cosmesis, 9.9% versus 11% for 40 gray versus 26 gray. This therefore should form part of the discussion points when discussing with patients. Moderate hypofractionation has also been shown to be non-inferior to conventional fractionation in prostate cancer management. Reference trials include the PACE 874, PCS5, PROFIT 1200, and CHIP 3200. In all trials, there appears to be no increase in acute toxicity. However, late toxicities tend to be worse but tolerable, hence patient discussion is warranted. It should also be important to note the following in analyzing the trial data to guide management: risk stratification, endpoint that was studied, radiotherapy technique utilized, use of ADT, and the duration of ADT to guide interpretation of results. Cervical cancer is one of the most common cancers in most regions in sub-Saharan Africa. However, there is no level 1 evidence which has looked at hypofractionation in radical treatment for locally advanced cervical cancer. Despite this, some clinicians in Africa have adopted hypofractionation, which has been noted from published survey data. Ongoing trials include the HEROIC trial, hypofractionated external beam radiotherapy for intact cervical cancer, which is a feasibility study looking at 40 grain 15 fractions of external beam radiotherapy and high-dose brachytherapy versus standard of care 45 grain 25 fractions external beam radiotherapy and high-dose rate brachytherapy, or with concurrent weekly cisplatin. Another trial in Mexico is looking with the same design. However, fractionation is 37.5 grain 15 fractions for the interventional arm. De-escalation in nodal volumes for lateralized head and neck cancers has been studied. For example, this study from Germany showed regional failure of contralateral neck was low after surgery and ipsilateral neck irradiation in head and neck carcinomas without midline extension. For palliative radiotherapy, there is established level 1 evidence for palliative radiotherapy utilization of shorter courses of treatment. Of note is a systematic review by one of my former colleagues, Dr. Edward Cho from Sunnybrook, who looked at 16 randomized trials with a total of 2,513 patients. Findings support utilization of shorter fractionations as no significant differences in responses were noted. But what has been the uptake of hypofractionation? Unfortunately, a recent study survey by one of my mentors and close associates, Dr. Daniel Rodin, showed global variation in use of hypofractionation and much less hypofractionation in low-middle income countries, Africa included, and Asia Pacific. Several reasons were cited, including lack of long-term data. What then can we do as a region to optimize radiation therapy utilization for centers with established radiotherapy departments? Educational interventions become important as open discussions on hypofractionation can be conducted, especially in situations where evidence is available. Policy implementations. Designing billing structures not based on traditional parameters, which include fractionation number and number of fields. Using patient advocates to aid discussions between clinicians and patients. Promotion of clinical trials in radiation oncology in Africa to increase the evidence base supporting radiation oncology choosing wisely initiatives. To conclude my presentation, I would want to acknowledge the AORTIC organizing committee, Queen's Global Oncology Group, Dr. Fidel, and Choosing Wisely team, my mentors, Dr. Nyakabau, Dr. Ndlovin, Dr. Rodin, and my family who have supported me throughout my career. Thank you.